I think we finished up at the lung cancer section last time when we were talking about asthma. So I think before we kind of go on to the next segment, what I want to do is number one, I want to address a question that came up last time that I just wanted to close the loop on. And then number two, I had 4 questions that were sort of related to asthma and COPD that I wanted to cover with you guys that I thought were relevant to the stuff that we discussed at. Can I just get a confirmation from you guys? Did we kind of like finished up with the asthma, COPD, lung nodules? Like that's some stuff that we covered last time, is that correct?
This is Zoe. I'm sorry. You may need to enter responses in the chat. I hear a yes.
Okay, yeah, I see. Yeah, thank you, Ashwin. Yeah, so I much appreciate it. Yeah, I couldn't remember. I'm actually doing concomitant board review for my residents right now, and so I get a little bit confused in terms of where I am because I'm covering a lot of similar stuff with them. So, okay, so first of all, at the last session that we did, I was asked a question in terms of the Fleischner criteria. So I'm going to actually go up to them here. And, I think the thing that we covered last time was, just in general interpreting the Fleischner criteria, and that sort of the big issue here was solid nodules versus ground glass nodules, and how ground glass nodules are a little bit more indolent, they grow more slowly, and therefore you have to monitor them for a longer period of time. With solid nodules, you only monitor them for 2 years, whereas with ground glass nodules that are a little bit, they're ground glass. They're a little bit not well defined on CAT scan, but they do look like there's a small, piece of schmutz there. That has to be monitored for not 2 years, but 5 years, because they can take longer to transform into malignancy. So anyway, the question was on this chart here, it says risk factors for lung cancer, right? So depending on whether this is considered a low risk or high risk patient, you will consider, you're going to consider managing them a little bit differently, right? So to answer the question, what it made somebody low risk or high risk, it basically was just do they have risk factors for lung cancer? So obviously smoking history, and then the other stuff I was able to find was, is it like history of lung cancer in a first degree relative? Is this somebody that has an exposure to something that causes lung cancer? Like obviously asbestos is the prototype, but radon and I guess uranium, not that I normally ask that of my patients, but apparently it's a thing. So anyway, that was the answer to that question. I didn't know that off the top of my head last. So we covered all this. So why don't we start, why don't we do a little bit of interactive stuff? So I'll give you guys like 45 seconds to read through this. And then depending on the question, I might solicit volunteers or I might talk you guys through it, just sort of, depending on the content, right? So why don't we start? I'll give you guys some time starting now. All right, guys. So, hi, Naga. Good to hear from you again. Would you mind walking me through your thought process in terms of how you worked through this case? If you're able to unmute. Oh, Zoe, do you mind? Would you let the audience unmute themselves?
Sure. Okay, go ahead and try to unmute yourself now.
Yeah, now I was able to unmute. So basically this patient, if we see, this patient has upper lobe emphysema, one thing. Second thing, the patient has been getting almost everything possible and still has quality of life is diminished. So in this situation, especially taking into consideration the upper lobe emphysema, in this case, if we go for lung volume reduction surgery, that would help in improving the overall quality of life and would be beneficial.
Absolutely. Thank you, Megan. It's perfect. Yeah. So this person's a great candidate for lung volume reduction surgery. So if we go back to what we had reviewed last week, so just coming back to where's the lung volume reduction here, right? So if we go back to the sort of criteria for lung volume reduction surgery, right? This is a person who has heterogeneous emphysema, right? They have upper lobe predominant emphysema. Their FEV is right in the correct point, right? It's between the 20 and 45% range. So and like Meg had mentioned, everything else has been done for this person. They're already on inhaled corticosteroid, a LAMA, and short-acting albuterol. So there's not really a whole lot else to do at this point. Now, in terms of some of the other answer choices, why they're not, probably the best, most appropriate thing for this person. So long-term azithromycin therapy. So this is not necessarily a bad idea, but really what azithromycin therapy is beneficial for reducing the frequency of exacerbations. And I think if you look at the question stem, it doesn't really talk that this person has any difficulty with like hospitalization for frequent exacerbations. His main issue was just decreased quality of life. So it's chronic breathlessness that he has. So the azithromycin therapy is unlikely to address that sort of chronic component. For C, roflumilast, this is a drug that's used for the chronic bronchitis phenotype. And remember, that's when a person has chronic cough for, I think, around 3 months. They do mention that this patient has a minimal dry cough, but it doesn't sound like a real true chronic bronchitis phenotype where it's a main component of his symptomatology. And then finally, in terms of supplemental oxygen, this patient's not hypoxic. Even during the 6-minute walk test, he desaturates only to 90%. So it's unlikely that supplemental oxygen is going to really get him a whole lot of benefit. So lung volume reduction surgery is probably his best option right now. And if it wasn't, then you might consider maybe lung transplant for him. All right, let's move on to the next bit. Okay, so I'll take this one on, right? So basically what you're dealing with here is you've got a young woman. She looks like she has exercise-induced asthma. She doesn't really have any symptoms at any points outside of the context of exercise, and her baseline spirometry is normal. However, when they actually challenge her on exercise testing, she's got that decreased FEV1 from her baseline. So they're asking here, where would you go in terms of retreat? So couple of things. The first issue with using daily salmeterol for answer choice A, remember that this is black boxed in asthmatics. You don't want to ever use it as monotherapy because the increased risk of death. So salmeterol as monotherapy is out. If you are dealing with a COPD patient, that actually would be a reasonable thing, but it's not something that you'd want to do given the fact that this is an asthma predominant case. Next, going to D, hypertropia before exercise. Remember that muscarinic agents are not really well studied in asthma. So they're also going to be suboptimal in terms of therapy. Can you use muscarinics? Absolutely. Especially, when you've used a lot of therapy, a lot of the basic therapy already. If you've started them on an inhaled corticosteroid, you've up-titrated, you put them on the long-acting beta agonist, you've trialed montelukast. If you have done all of the basics, then sure, probably some tiotropium is not going to hurt, but there's not really a lot of evidence that it has benefit in asthma. So certainly you wouldn't use it as first line, and you're not going to use it as something that as a PRN, with exercise. Then in terms of B and C, these are pretty similar answers. And honestly, from my standpoint, I think that both are reasonable choices, either doing standing budesonide inhalation or doing budesonide formoterol before exercise. Considering that this patient really just has symptoms in the context of exercise, probably the best strategy here is to use the as needed inhaled corticosteroid LABA before exercise. Probably this patient does not need standing budesonide because right now she's training for a marathon and she's probably not going to be training for a marathon forever. So because of that, she's probably not going to need to be on it as standing therapy. And remember that this is kind of a new paradigm that's been emerging in guidelines over the last couple of years. It's not something that we're used to doing. Before, we would have done an as-needed short-acting beta agonist before exercise, but now they're saying either you could do a short-acting beta agonist with an as-needed inhaled corticosteroid before exercise, or you just do the ICS-LABA combination. And again, that is, if we go to the point where we talked about this in asthma, right? Remember that you have two potential tracks. And so here, for this patient who has infrequent symptoms, you can go with an as-needed low-dose inhaled corticosteroid and formoterol, or you can do just an inhaled corticosteroid whenever you use your short-acting beta agonist. So in the chat, Ashwin has a question. So he's saying, how can inhalation steroids, which are like immunomodulators, work on acute conditions like exercise-induced asthma? So I think that's a good question. I don't think that they do. I think that the inhaled corticosteroid component is not really there for the acute issue. I think that the part that really is helping people with acute issues like exercise-induced asthma that have infrequent symptoms is really the long-acting beta agonist. So it doesn't really matter, I think in my mind, whether you're giving them the short-acting beta or the long-acting beta agonist. They both are going to work fine. I think that the paradigm shift of using an inhaled corticosteroid whenever you have breakthrough symptoms is really more to it's kind of like titrating the amount of inhaled corticosteroid they're exposed to how frequently they're having their symptoms. So I think if somebody is having daily symptoms and you're going to be obviously be putting them on daily preventative anyway, but I think the inhaled corticosteroid is not really there. The purpose isn't necessarily to treat their acute exacerbation. I think it's really there to prevent recurrent asthma symptoms later on within the next couple of days. So Ashwin, I think you're absolutely right. It's not part of the acute therapy, but it's part of the treatment. When you need an as-needed beta agonist specifically to prevent symptoms, the day after. So that's why. I agree that they don't work rapidly enough to give you symptom relief right now. That's why you're not using an ICS as monotherapy on a PRN basis. If you look at track 2 here, for the patients that are having symptoms that are infrequent, but greater than or equal to twice a month, they actually mentioned that you should just be on the low-dose maintenance inhaled corticosteroid. So you're either going to do inhaled corticosteroid and when you're using the short-acting beta agonist, or if it's frequent enough, then you should be on maintenance like controller therapy. That makes sense. So looking back to the question. Okay, yeah, so that's that. All right. Here is our next The next round, let's get started. We have this one and then one more afterwards, and then we'll get into a little bit more didactic stuff. Alrighty. Thank you, Mega. I appreciate you putting yourself out there. I'm going to do this one. I'm not going to, I won't torture you. So because I appreciate that you had helped me out with the first question. So I'll run through this one for you guys, right? So here we've got a 57-year-old woman. She's gotten not very well controlled COPD, right? She's on all the usual stuff, right? She's on a short-acting beta agonist. She's on ICS, LABA, and a LAMA. And she takes her medication. She's compliant with her inhaler technique, all that stuff. She's frequently getting exacerbations, right? They mentioned that this is her third exacerbation. She's got obviously pretty advanced COPD with her FEV1 over FVC ratio being at like 45%, and she's done the good old pulmonary rehab. So she's kind of gotten like the kitchen sink already. So they're asking you, what are you going to do for her in terms of long-term treatments? So I think I get that this is a kind of a softball question. I know we already talked about how azithromycin can be utilized for the prevention of recurrent re-exacerbations when you already have somebody on maximal sort of standard therapy. So obviously azithromycin is the go-to. I kind of want to talk about some of the other stuff and really talk about why you would not use that, right? So we didn't really mention alpha-1 antitrypsin augmentation therapy previously. This is obviously for somebody that would have alpha-1 antitrypsin deficiency. So obviously this person doesn't have any history of AAT deficiency, so it's not something that you're going to use for them. Oral N-acetylcysteine is also out. These both azithromycin and NAC are sort of a little controversial, but NAC is much more controversial. And I don't think there's really a whole lot of data that it does anything in the management of long-term COPD. So you wouldn't use NAC. And then finally, C-metoprolol. This one, I think it was worthwhile talking about briefly. So the data for using beta blockers in people who have bronchospasm are kind of all over the place. So initially, I think the beginning data showed that people that had COPD that were on metoprolol actually had better outcomes. And then subsequent to that, some data came out that actually they maybe don't do as well. But I think the bottom line is, despite the fact that there's kind of a paucity of evidence, the preponderance of evidence in this domain states that first of all, you shouldn't be really using beta blockers as part of COPD therapy. It's not a treatment paradigm. However, it's actually considered to be relatively safe if you need to use it for concomitant issues. So a lot of our smokers, they have COPD and they also happen to have coronary artery disease. It's fine to give them beta blockers. You should really focus on giving them a beta-1 selective like metoprolol. So try to avoid non-selective beta blockers in COPD patients, especially those who are, not really well compensated in their COPD. But overall, beta blockers, I believe, are considered safe for use in patients who need them for other indications. So while you wouldn't necessarily give this patient metoprolol if she had coronary artery disease and needed to be optimized for coronary artery disease, then metoprolol is actually fine to use for her. But again, you wouldn't use it as a targeted COPD therapy. There's no data that it actually helps with COPD. All right. And the clopidogrel. All right. So let's walk through this question. So this is a little bit different from what we had talked about earlier, right? So this patient has bronchiectasis as opposed to all the COPD that we had done previously. So this person is here with what looks like bronchiectasis exacerbation, and right. So yeah, productive cough is worse in frequency and severity, and their sputum is worse. So they're asking you, how do you treat a person who has bronchiectasis exacerbation? So remember when we go back to our discussion on bronchiectasis therapy, where we talked about that and CF, which are pretty similar. When you're dealing with a bronchiectasis or cystic fibrosis flare, their big issue is that they have a chronic elevated bacterial load. So the preferred thing that you want to use for these patients usually has some sort of Pseudomonas coverage, and fluoroquinolones are considered to be the mainstay of therapy. Steroids are not going to be particularly helpful in people who have cystic fibrosis unless they also happen, or bronchiectasis, unless they also happen to have some sort of bronchospastic thing. So if they have like an overlap of bronchiectasis and COPD, yeah, sure, you could use corticosteroids, but most people are, pretty cut and dry where they have one thing or the other. In terms of some of this other stuff, chronic azithromycin you can use for bronchiectasis, but it's really more of a maintenance therapy to reduce the bacterial load. And remember, before you put somebody on azithromycin, you have to make sure that they don't have a chronic mycobacterial infection. It's not used like ciprofloxacin, for example, for an acute exacerbation, because you kind of are going to treat them sort of like they have a pneumonia when they come in for an acute exacerbation. Azithromycin monotherapy is not really going to be as beneficial. And then inhaled Dornase alpha, yeah, you can use that again as a maintenance therapy in people that have bronchiectasis or CF, but it's probably not going to be particularly useful in the context of an acute exacerbation. Okay, so let's go on to ILD. I love ILD. I used to hate it when I was a student, and I hated it even more as a resident because there's so many of them, but I've grown to really love it over the years. I guess mostly because I teach it, so I feel like a little bit more comfortable with it. So what I'm going to try to do with you guys is I'm going to try to water ILD down into just a couple of core concepts and make it a little bit easier for you guys to identify what kind of ILD you're working with, and try to get you towards a path of how do I think about these, and then how do I think about the management of individual ILDs. So first, why don't we start with what causes ILD and sort of the big players here. So from a drug standpoint, there's only a handful of things that are really common that we see that I think should be kept in mind. So amiodarone, very common drug toxicity. We use amiodarone a lot in clinical practice. Methotrexate as well. When people are on either of these drugs, they probably need to have intermittent monitoring for pulmonary toxicity. I would imagine that usually it's going to be the prescriber, and given our audience here, since I think this is mostly internists, you guys are not really going to be doing the monitoring yourselves. I believe that this is something that the cardiologist or the rheumatologist would do, but it is something to keep in mind. These people probably should have some baseline pulmonary function testing or baseline spirometry, and then intermittent spirometry, I would guess, every 6 months while they're on the drug, because it can cause pulmonary toxicity in the long term. Nitrofurantoin, I have never seen this because nobody really uses nitrofuran long term. I guess, as a hospitalist, I don't really have that kind of exposure with it. But if a person is getting long-term nitrofurantoin prophylaxis, I'm assuming for like recurrent UTIs, that's something that can cause an issue. And then obviously there's many different kinds of chemotherapy that can cause pulmonary toxicity. Bleomycin, busulfan, lots of stuff. I mean, I'm not an oncologist, I'm not going to go through it. But if somebody's getting chemotherapy, just keep in mind that a lot of them have pulmonary toxicities, and you have to be mindful that maybe it could be the cancer, it could be the chemo. Right? Chest radiation is also a potential player. Typically, when people get chest radiation, it's not like, the gamma knife brain radiation that you guys are accustomed to seeing. Usually chest radiation happens within a radiation field, and it's typically a substantial amount. So when somebody gets chest radiation, they can get pulmonary damage and inflammation from that. timing usually happens about 1 to 3 months after the radiation. So it's not like you get radiation and then the next day you're sick. It takes a couple of weeks to kind of start to develop inflammation. In this context, when somebody has radiation pneumonitis, you generally treat it with steroids. And most of these patients are not going to get fibrosis, but some of them will develop it, and that usually takes about a half a year to really start to see those fibrotic changes. I'm going to show you guys some pictures as we go along, so that we'll be able to differentiate the changes that you see in inflammatory lung disease versus the changes that you see in fibrotic lung disease. Smoking is obviously a big player. There's not a lot of stuff to know here, aside from every patient should stop smoking regardless of what they have, right? So I don't know why, but on MixApp, there's always going to be like a couple of questions that say, what do you do with this person? Yes, of course, smoking cessation. It doesn't matter what their underlying problem is. Now, there are 4 types of ILD that have kind of a stronger smoking association than the others. So there's something called RB-ILD, which is respiratory bronchiolitis ILD. There's desquamative interstitial pneumonia, DIP, Langerhans cell, and a new one which I just learned about the other day called SRIF. And then when I looked up what SRIF stood for, it's smoking-related interstitial fibrosis. I don't know why we keep on getting the words but okay. So the reason why I kind of bring these to the forefront, you guys don't have to know how these look. You just have to know that these are very, very heavily smoking associated. The other ILDs, most of them actually do have some smoking association too. So it's not like these are particularly special, but especially let's say you're dealing with a patient that has RB-ILD specifically, if they stop smoking, their ILD will stop progressing. Whether or not they regress once they stop smoking, I think really is going to depend on the individual patient. But certainly you can, specifically with RB-ILD, you will actually arrest their ILD if you get them to stop smoking. So smoking has obviously critical cost here. Chronic aspiration pneumonitis, I think a lot of you guys encountered this before. There's nothing to say. It causes pulmonary fibrosis. Pneumoconiosis is not something that I think we see in New Jersey. We don't have like a lot of coal miners here, but we will talk a little bit about asbestosis a little bit later, either today or tomorrow. Autoimmune disease is certainly a player when you've got people with especially systemic sclerosis or CREST syndrome. They are at risk. We'll talk a little bit later about pulmonary hypertension, but when you are working with scleroderma patients, they're at higher risk for getting pulmonary fibrosis. And when you have people who have CREST syndrome, that kind of like limited systemic sclerosis, those people are more likely to get pulmonary hypertension. They both can get both, right? So scleroderma can get either pulmonary hypertension or pulmonary fibrosis, and the same thing goes for CREST. It's just one has so scleroderma has a higher predilection for the fibrosis, whereas CREST has a higher predilection for pulmonary hypertension. I don't really know that that's helpful information for you guys to know, but I figured let's just cover it anyway. There is an entity known as anti-synthetase syndrome, where you get either dermatomyositis or polymyositis and an ILD associated with it, and that ILD can be especially bad. So I think, just examine them for autoimmune disease, like you would do a normal screening exam on everyone, right? So if they have like the weird, Gottron's papules and the mechanic's hands and all the findings of dermatomyositis, maybe you know where their ILD is coming from. Hypersensitivity pneumonitis, I don't really know why I included it on the slide. I actually have a separate thing where we're going to talk about it. I don't really have anything special to say about it. So we'll get to it when we get to it. So I think most important thing, and I know I'm probably not surprising any of the seasoned hospitalists here. So this is sort of more geared to our trainees, but I really want to impress on some of our younger attendees in terms of when should you be thinking about ILD? And most critical thing here is that you should be considering ILD in a patient who looks like they have pneumonia. Obviously, when you have a person who is coming with pneumonia, I'm not telling you to start thinking about ILD at that point. The most common thing that I've seen in the hospital that sort of leads to a diagnosis of ILD is a person who has coming with pneumonia, had multiple treatment courses of antibiotics, and is not responsive to the antibiotics. it's not because you're making the wrong antibiotic choice. Most pneumonia should resolve with empiric antibiotic therapy. So if somebody gets treated with antibiotics and they don't get better, it's probably because the diagnosis initially was wrong. And a lot of times there's no way to really get to the ILD diagnosis until you try to treat them and you don't get anywhere. So just keep it in mind, if you treat them with antibiotics and it doesn't work, maybe you're banging your head against a wall because they actually don't have an infection, they have an autoimmune condition. These people are more likely to be atypical in their presentation, so they're unlikely to, they're less likely to have a lobar pneumonia. They're more likely to look more like the walking pneumonia, sort of peripheral infiltrates that you might see with like a Legionella or a chlamydia pneumophila case, or a mycoplasma case, right? But otherwise, I mean, they're going to get the same symptoms: cough and shortness of breath, right? So in terms of the workup for any kind of ILD, usually you're going to start with spirometry, you're going to get an x-ray. Keep in mind that if they have early ILD, your x-ray and spirometry might be normal. So really the way to diagnose or exclude ILD is with a high resolution CAT scan. If their high resolution CAT scan is normal, they don't have ILD, they have something else. But your spirometry might not be affected if you've got really early ILD. Somebody that has a little bit of ground glassing from their hypersensitivity pneumonitis, they're not necessarily going to have big changes on the spirometry. Ultimately, if you want to diagnose these patients, the best way to do it is with a lung biopsy. You can try to do a bronchoscopy and a transbronchial lung biopsy, but the problem is that they can't get a lot of tissue. They're using a needle that traverses a bronch. So you can get some stuff by bronchoscopy, for example, with eosinophilic pneumonia. When you do a bronchoalveolar lavage in a patient that has eosinophilic pneumonia, you're going to get eosinophils, right? So that you can diagnose pretty easily with bronchoscopy. If somebody's got sarcoid, sure, you could biopsy their mediastinal adenopathy and you can find their granulomas. It's pretty straightforward. But for the other stuff, really the way to make a good tissue diagnosis is that you need to see architecture. It's kind of like looking at a kidney biopsy, right? Where you're trying to differentiate membranous versus membranal proliferative versus blah, 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 right? You need to figure out how many of the glomeruli are affected. Is it a glomerular disease? Is it an interstitial disease? Are the tubules involved? You can't get that by just aspirating cells. And that's really the problem with a transbronchial lung biopsy, is your needle is not really thick. So ideally, if you want to diagnose these people, it's going to be VATS as the strategy for lung biopsy. But unfortunately, most of them aren't, and they end up being too sick to actually get a lung biopsy. So a lot of times we're going to be identifying them and treating them on the basis of their imaging findings and whatever limited bronchoscopy results we're able to get. So that's that. So let's do a little bit of a radiology review. This is my favorite part. I love looking at images. I'm not a radiologist, but I aspire to be one someday for the money. Okay, so let's talk about reticular infiltrates. So supposedly this X-ray has reticular infiltrates. This is something that I'm absolutely terrible at. I don't know. I took it off of Google Images from somewhere, and I think if you showed this to me in a healthy patient, I would say that they're healthy. But I don't know. Apparently there are intersecting lines that you're seeing in some sort of pattern here. I don't see it. I'm blind to reticular infiltrates for whatever reason. You know what I'm not blind to, though, is this. So this is a really frank finding, right? This is traction bronchiectasis. So what you're seeing in this sort of sagittal image is you're seeing somebody that's had pulmonary parenchymal destruction. And because their parenchyma has been destroyed and it's been replaced with scar tissue, that scar tissue is now kind of pulling apart that bronchus. You normally are not going to see, with typical traction bronchiectasis, it's not going to be this dramatic. I mean, I intentionally picked a picture that was obvious, but I think when you look at a number of CAT scans, you'll get a feel for what is sort of the normal diameter of a bronchus, and they really should be sort of well-defined, circular, and linear, and that's not what you're seeing here. Here you're seeing this very large dysmorphic ectatic bronchus, and this all should be filled with lung parenchyma. It's not. It's filled with air because the lung parenchyma has been destroyed. Now, the other thing that's interesting about this picture is that you have a lot of really dense you've got a lot of dense sort of pulmonary opacity that is happening around the traction bronchiectasis. It's hard to tell what's in there on the basis of a CAT scan, right? This is just really thick tissue. Is there inflammation in there? Or is there scar tissue in there? Is there a mass in there? Could there be a mass somewhere up here? I don't know, maybe. So it's kind of hard to tell because there's this sort of surrounding consolidation. We're gonna compare traction bronchiectasis to air bronchograms. Hopefully I remember to show you the difference between the two in some of these upcoming images. This is an example of honeycombing, right? You guys have all seen this. I'm not really wowing anybody here. Honeycombing is like traction bronchiectasis in the context that this represents fibrosis, right? Both of these findings happen due to tissue destruction. So either one that you see, you're dealing with some kind of fibrotic lung disease. Compare and contrast this to this sort of reticular pattern. A reticular pattern on X-ray typically corresponds to ground glassing on CAT scan, which I'm going to show you guys in a second. So reticular pattern, ground glassing, those words, those findings represent more inflammation, whereas traction bronchiectasis and honeycombing represent fibrosis, right? And depending on whether somebody has an inflammatory lung disease or a fibrotic lung disease, that's going to help you with A, making a differential, and B, figuring out what kind of treatment am I going to try to go with for you. All right, so we're on to ground glassing. So this is sort of one of those more inflammatory findings, right? So what you're looking at here, if you compare the lung on the left to the lung on the right, the lung on the left is dark. It's pretty normal lung parenchyma. Whereas here on the right-hand side, you see that it's a little bit more bright, it's a little bit more opaque. And it's sort of in a mosaic pattern, right? So some of these areas, like here, are a little bit bright, and they're adjacent to areas that are a little bit darker, which are more normal lung parenchyma. Ground glassing is not specific. It doesn't tell you what's in the alveoli, just that there's something there. It could be blood, it could be pus, it could be fluid. This could be heart failure for all I know. I mean, I don't have the rest of the CAT scan to tell you. But the bottom line is, I think when we're talking about this in the context of an interstitial lung disease, ground glassing represents typically inflammation. So I found this awesome picture on Google Images, God knows how long ago, and it shows you pretty much everything, right? So you've got consolidation. Within this consolidation, you see some bronchi, right? These are air bronchograms. Compare and contrast these to the traction bronchiectasis that you saw earlier, where you actually had like a widening and an ectasia of the bronchus, where you don't really see that in this traction bronchiectasis. So this is just regular consolidation, right? We looked at a couple of fibrotic patterns earlier, and we saw some ground glassing. I don't know what the atoll sign or perilobular pattern is, and I don't care because I'm an internist and I'm not responsible for interpreting these images on a full-time basis. But the basic findings that I've shown you really can help to guide in terms of figuring out sort of what is the style of ILD that you're dealing with. Okay, a couple more things. So septal line thickening, right? So here you can see the interlobular septa. They're thicker, right? On the left side of the lung, you're not seeing that quite as much, but you are seeing a lot of it in the periphery of the right side of the lung. Septal line thickening is just another form of fibrosis. You might see this initially, and then eventually progress to like honeycombing and traction bronchiectasis. So this is a fibrotic type of pattern. When you talk about nodular distributions, this I think is probably a little bit lower yield. I don't really think that they're going to be asking you to interpret these kinds of images when it comes to board exam. But I figured, you know what, we might as well, just for the sake of having the review pattern. So you're really going to see, supposedly, one of two patterns when you're dealing with lung nodules. You're either going to see something that's centrilobular, right? So here they have the lung lobules outlined. So here are your interlobular septa, and then they're centrilobular, right? So these nodules are right within the lobules. And this is opposed to a sort of a more perilymphatic distribution, which is not really commonly seen. I can't even imagine. I can't think off the top of my head what might be a perilymphatic disease. Malignancy, I guess? I don't know. So, and then obviously random is none of the above. So let's take a look at some of the other buzzwords that you might hear about. So number one, let's look at hilar adenopathy, right? So when you're looking at the chest X-ray, these are your highlight points. I don't have a lot of image attributions, but guys, there are no images here that are mine. I stole these off of Google, so I don't own these, and they're somebody else's work. But I don't know. I forgot to attribute them. I just found them, and they're great pictures, right? So these are your highlight points, and this is what a normal X-ray looks like. On a CAT scan, when you see hyaluroadenopathy, that hyaluroadenopathy, I guess the way to identify it is look at the CAT scan and look at the organs. You should be able to identify every structure individually, right? You've got your heart, you've got your pulmonary trunk, or these are, I guess, your pulmonary veins. You've got your descending aorta. These dark areas here, these are your bronchi. And then you have this thing. What the hell is this thing, right? This is a structure that's not supposed to be there. It's not a blood vessel. It's clearly not lung parenchyma. It's something else. This is hyaluroadenopathy. You also see kind of the same thing on the other side here too. We only have one slice of the image, so I don't know if this is maybe a slice of a blood vessel or what. But I think the bottom line is this thing that's not enhancing with contrast, it's just extra tissue. What is that extra tissue doing there? So this is either hyaluroadenopathy or just a frank lung mass. Kind of hard to say just based on one slice of the CAT scan. You're usually not going to see a whole lot of stuff in the sort of posterior mediastinum. The main thing that lives here is the esophagus, and then if you go up a little bit higher, it's going to be the intrathoracic trachea. But those are the only two things you should see here. So if you're seeing extra stuff, if it looks like a little bit extra meaty to you, then maybe you're dealing with some mediastinal adenopathy. So this is what hyaluroadenopathy is going to look like on CT. All right. Before I move forward, I can't believe I almost forgot to show you guys a picture. I went back in time and I actually found a patient of mine that had a variable intrathoracic obstruction, and I wanted to show you guys the CAT scan. So remember with the variable intrathoracic obstruction that we talked about last week, the tracheomalacia happens within the thorax. So I have a great picture of it. For the first time in my life, I saw this, and I wanted to share it with you guys because it's awesome. All right, so if you start off at the top, right? So here you're looking at, this is my image. This is the only image that I actually own, right? So this is my patient I took care of about a month ago. So if you look here, you start at the top, this is the extrathoracic trachea. And you can see that it's beautiful, right? It's surrounded by cartilage. It's stented open because of that cartilaginous structure. As you go down into the chest, look at what happens to the trachea, right? So here, the trachea is sort of like a half crescent. It's not supposed to look like this. It's supposed to be a perfect circle. The reason it's not a perfect circle is because the cartilage within the trachea has degenerated. And here you can actually see the esophagus behind it is sort of like, it's like a little bit patulous or distended. It's got some air in it. I guess that's fine. But typically, you can't even see the esophagus on CAT scan because it's collapsed. It doesn't have any air in it. So this trachea is so incompetent. It's so floppy that it's allowing the esophagus to just bully it around. That's not normal. So this is a variable intrathoracic obstruction. This is classic tracheomalacia. I've never seen it in my life until I looked at this person's CAT scan. So awesome. Anyway, just wanted to digress. And now let's get back to the good part. Let's see, more pictures. Okay, so we did hyaluroadenopathy. All right, so I'm gonna, at this point, we're gonna do a little bit of radiology around. So I'm gonna show you guys a couple of pictures and, oh, thank you, Sherry, much appreciated. I'm gonna show you guys a couple of pictures and we're gonna do this exercise together. Some of these pictures are better than others, so I apologize in advance. So I'm going to show you guys a picture, and I'm going to give you like probably 30, 45 seconds with every picture. I'm going to let you digest it, and if you guys don't mind, just put into the chat what findings you're seeing. You can feel free to unmute yourself and speak up, and we're going to try, as a family, to diagnose these patients on the basis of CAT scan alone. So now that I've kind of shown you guys a bunch of the sort of photography, I'm going to ask you guys to try to identify some of that on these individual CAT scans. So why don't we start with this? I'll give you guys like 30, 45 seconds to digest, and we'll go. Fabulous. And thank you so much for putting yourself out there, guys. Some of these pictures are difficult, and I'm personally like very interested at looking at CAT scans, but I fuck them up all the time. So, I appreciate you guys putting yourselves out there. So, number of people had mentioned ground glassing. Yeah, so this person has a lot of diffuse ground glassing. You see a lot of that in the sort of posterior left lung, and you can see it's kind of like that mosaic pattern that we were talking about earlier, right? So you've got this sort of dark area here, and then it's surrounded by like lighter lung over here, and then another dark area here, more dark area here. So this pattern of some lung parenchyma is a little bit brighter, some lung parenchyma is a little bit darker, is ground glassing, right? So that ground glassing, I mean, here it's even more frank, right? You've got a very nice dark circular region surrounded by some more patchy, brighter regions, right? So this is non-specific, but this patient clearly has inflammation. A couple of people had mentioned traction bronchiectasis, and I'm really glad that you guys mentioned that, because this is like, for me, I really always struggle with this distinction. So I actually think these are normal bronchi. The reason that they look like they're maybe bronchiectatic, or the reason I guess that they look so much more prominent, is just because the surrounding lung is ground glass like that. So it just kind of makes them stand out a little bit more. So my guess is, again, I'm like a peasant radiologist here, but my guess is these are probably more normal appearing bronchi. They're pretty circular when you get them on that like axial section, and then when you get them on more like, I don't know, I guess a sagittal section or coronal section, whatever plane that bronchus is in, they're pretty linear, right? With a traction with a kind of ectatic bronchus, they're going to be slightly bigger than this, not much, just a little bit, and they're going to have like a little bit of an irregular appearance. So that's number one. The other thing, which is very, very, very subtle on this image, and I actually had to pull this image up at the last minute. This is what I was working on, which is why we started a couple of minutes late. The other thing is that this person has a little tiny bit of nodularity. It's very subtle finding here, but I think radiologists are like much more trained to look at this than we are. So where are the nodules, right? So this thing is probably not a nodule. It's probably a blood vessel that we have just in transverse section, but maybe a nodule here. This thing here is very likely to be a nodule. There's another dot here, there's another dot here. There's a lot of little dots all around, especially looking at the anterior segment of the lung here. There are a couple of these are blood vessels, but a few of these dots are going to turn out to be nodules. I picked this picture because this is a good example of a central lobular nodule. You would not believe how difficult it was for me to find it. I mean, I Googled central lobular nodules for like a good 30 minutes. I could not find a really good picture. This is a nice one. So here, you've got your lung lobule pretty well defined, and it's nice that it's ground glass because it makes it kind of pop out a little bit. You've got a nodule right in the center here. This is probably another central lobular nodule, although the lobule and the interlobular septa are not super well defined. You do have like a little bit of a septa here, and maybe a little bit. It's not that clear. So this is a picture of hypersensitivity pneumonitis. And these are sort of the findings that you would be, expecting to find in hypersensitivity pneumonitis. This is a person that has a lot of ground glassing. They're very inflamed, and central lobular micronodules, which is exactly what I showed you, is kind of a classic finding in hypersensitivity pneumonitis. So this is the hardest one. Okay, I swear they're going to be easier than this one. Okay, let's begin the digestion. What are we looking at here? Fabulous. I love you guys. Thank you so much for participating. You're the best. All right. So you guys are right. So this is like, we're dealing with a fibrotic lung disease here. So obviously you got the arrow sign here, right? You have a ton of honeycombing in the bottom left lung, and also sort of in the periphery of the right lung. Betsy mentioned fibrotic strands. So I agree. I think if you look here, right, this is like the interlobular septa, and it looks thickened, right? A normal interlobular septa, I guess, should look like this. It should be very faint, like what we were looking at in the other pictures. But here you've got this like thickened interlobular septa. Here the septa lines are they're pretty thickened. The other thing here that you're seeing, so this I think is traction bronchiectasis. So take a look at this bronchus here, specifically in this area. You guys see how in the periphery, it's like kind of more linear, but then as we get close to the mediastinum, it's not quite linear. It's a little bit like undulating, and it's sort of thick. Compare this bronchus to the last one that we saw here, right? You see how this one is like, it's just the diameter smaller, it's more circular, it's more linear when you look at it in like sort of the sagittal section. They're a little bit different. This is, I think, traction bronchiectasis. And I mean, thinking about this kind of as a whole package, right? Traction bronchiectasis in this image, it just tracks, right? Because this person clearly has idiopathic pulmonary fibrosis, right? They have that honeycombing, the interlobular septal thickening, and I would expect them to probably also have traction bronchiectasis because they have destruction of their parenchyma. There's some of this thick stuff around the bronchiectatic segment. I don't know what's in there because it's too thick to tell, but probably this is all just scar tissue, is my guess. And then Ashwin, you mentioned compensatory emphysema. I'm not sure. I'm honestly not personally, I'm just not very good at identifying emphysema on a CAT scan. I mean, the things that I know to look for are kind of bullae. I'm not very good at identifying emphysema by looking at the pulmonary parenchyma. It's just not something I've ever really gotten a good grasp on. So I'm not sure. But I think definitely there's traction bronchiectasis, and the reason that that's happening is because the pulmonary parenchyma has just disappeared, right? So now you just have a lot of these empty spaces, and functionally these are kind of bullae, but unfortunately they're just everywhere. So at this point it's straight frank honeycombing. So this is a classic picture of idiopathic pulmonary fibrosis. They all look exactly like this. Okay, time for some fun. I'm showing you two CAT scans. One lung looks larger than the other, so compensatory. Yeah, I guess so. I would agree, right? Because if the entire left lung is bronchiectatic, if the entire left lung is honeycombed, and it's sort of fibrosed, that's going to scar the lung down. It's going to reduce the lung volume. So, yeah, I mean, here the right lung looks much bigger, and also the entire mediastinum is kind of shifted over to the patient's left. So, yeah, I don't disagree. I think I didn't notice that when I first looked at the CAT scan, but yeah, I think that you're correct. All right, thanks, Thomas. You're the best. All right, let's do this one. So what we're looking at here, this is a CAT scan on, just humor me, just pretend like both of these pictures are at the same level. The difference in these two pictures is time, okay? So this is the same patient at time 0 and at time 3 weeks. Okay, fabulous. All right, so let's walk through this. So I got a couple of possibilities here. So first thing, we mentioned traction bronchiectasis. So I don't think that this person has traction, and the reason I'm saying that. So why don't let's just forget about the diagnosis for a second. Let's just kind of talk about what's the global pattern of findings that we're seeing, right? So let's see. So Betsy, you mentioned consolidation. I agree, right? This person has a consolidation here, and then a month later, that consolidation is gone, but they have another consolidation here, right? So there's some schmutz there, right? Adjacent to this consolidation, you see ground glassing, right? And you see ground glassing here. That's not that surprising. I don't know what's in there, but it's inflamed, right? So maybe it's an infection or it's an inflammation from another cause. You see other areas of consolidation here. There's a little bit of ground glassing that's next to them, right? Another area of consolidation here, some ground glassing. So this person has some sort of inflammatory process going on. You know what I'm not seeing? I'm not seeing honeycombing. I'm not seeing that interlobular septal thickening. I'm not seeing any pattern of fibrosis, right? So my initial bias when I'm looking at this CAT scan is I don't think this person has any kind of like fibrotic lung disease. So it would be weird if they happen to have traction bronchiectasis just on its own. So that's why I'm saying like we should look at the constellation of things in order to kind of tease out what exactly we're looking at. So I would say, you know, again, as a non-radiologist, probably this person doesn't have traction. And the reason is that they don't have any other signs of fibrosis. So it would be weird that they had that and only one finding of fibrosis. These little like holes here, these are just kind of like axially cup bronchi, right? I think that these are fairly reasonably sized. Now, looking at this area here, these bronchi are a little bit larger. And so I could see why, I could see why that might look like traction bronchiectasis. You can compare them to this, and they're actually pretty similar size. I think that the reason that they're a little bit bigger is that these are the immediate branches that are coming off of the left, like the right and left main stem bronchi. And because of that, they're just a little bit more plump. But probably my guess is there's no bronchiectasis. It's just there's no fibrosis, right? So I think what we're looking at here is mostly some kind of inflammatory thing. Now, so Ross mentioned recurrent aspiration, right? And so Ross really like astutely picked up on, why am I showing you a CAT scan at 2 different points of time? And so you're totally right. Recurrent aspiration 100% could look like this, right? You aspirate, you get one consolidation and like a lot of inflammation there, it gets better, and then you aspirate again. Now, I would push back on the recurrent aspiration on the basis of, A, I'm talking about ILD, right? So I'm probably not talking about an aspirator. And also it's boring, right? Nobody cares about aspirator. I mean, because there's nothing you can do. It's like the most unfulfilling thing you manage in medicine, right? But number 2, this person also doesn't have fibrosis, right? When somebody has recurrent aspiration, long term, that tends to be more of a fibrotic kind of issue. It's like they aspirate, they get a little pneumonia, they get better, and then they just kind of get more and more fibrotic over time. So probably not recurrent aspiration, but it could be. I mean, maybe this is just really early in the disease course. And then Ashwin, you mentioned subpleural plaques. I'm not seeing them on this. I think what you might be looking at is you might just be looking at like the ribs because they have like this person just has really thin ribs on the section. I actually have a really good picture for you for subpleural plaques. So just remind me, we're going to talk about asbestos, and I have an awesome picture of plaques. You know what? Screw it. Let's do it live. I'm going to show you subpleural plaques right now. It's all the way at the end. I don't even know if we'll get to it today. Oh my God, 120 slides. Are you guys ready to just suffer with me? Okay. So here's a picture of subpleural plaques, right? So this is a person with asbestos exposure. I probably should just move this image up to the top, right? So here you can see this person. So here are the ribs, right? And then these are calcified plaques on the peripheries. And this is sort of like classic pleural plaque that you see in asbestos. These are calcified. I don't know if that really tells you anything about how nasty or cancerous they may or may not be, but that's what they look like. Okay, so back to the good part. Let's see, where are donde están los fotos? There we go. Okay, so anyway, what we're looking at here, this is cryptogenic organized pneumonia. This is a picture of it. So I'll talk to you guys about COP and BOOP in a second, but essentially the symptom complex of cryptogenic organized pneumonia is somebody that gets pneumonia, you give them antibiotics, they get better, and then they get it again, and you're just like, stop getting pneumonia, right? So it looks like a person that just gets recurrent pneumonia, and that's why I'm showing you, well, look, initially they had this infiltrate, and then it went away, and a few weeks later, there's like multiple infiltrates elsewhere. What the hell is going on? So they look just like pneumonia, and that's why it can sometimes be very difficult to diagnose them because they fail antibiotic treatment. You're just like, what am I doing? I think I'm the shittiest doctor ever. It's not your fault. They just don't have an infection, right? And the conditions look identical. So anyway, so this is COP-BOOP. I'll talk a little bit more about this in the coming slides once we're done with some pictures. Oh, what the hell are we looking at here? Now I have to remember this one because there's a lot going on. Betsy, can you do me a favor? If you don't mind terribly, would you mind unmuting yourself and telling me why you said the word traction bronchiectasis? Because somebody said it like the last 5 slides, and I mean you're really putting yourself out there. So I just want to hear your rationale.
The first thing that struck me on the I think the right side, I'm not able to point the arrow. This looked very prominent. Maybe I'm wrong. I think it's, now I take back what I just typed. I think it's more fibrotic strands that's probably making it look like traction bronchiectasis. I may be wrong. It's just, I think it's more fibrosis than traction bronchiectasis, I guess.
No, Betsy, you're right. That's why I asked you to explain your thought process. So that I think that I'm not trying to make a pun here. So traction bronchiectasis for this patient, it actually tracks, right? With the broader complex. I totally agree with you, right? I think you're seeing a lot of very thick, a lot of this interlobular septal thickening here. Obviously here, I mean, the lung is just, it's very bright and very dense, right? So I agree with you. This person has fibrosis. And you know what fibrosis patients get? They get traction bronchiectasis. Now, you might say, oh, Krister, like these are like so tiny, right? Like, is it really traction? Yes, it is. Because look at the way that this bronchus looks. Do you see how it's all tortuous and like nasty looking? I actually think this person has a little bit of traction bronchiectasis. Again, I'm not a radiologist. Me and you could be totally wrong on this, but maybe, right? It kind of looks like just a smaller version of that picture that we saw earlier. Now, why is this bronchus smaller? It's probably because it's just really peripheral, is my guess. But I think the bottom line, you know what I'm doing here is I'm trying to look at the big picture. I'm trying to see, is there fibrosis or not? And if there's fibrosis, I'm like, yeah, maybe there's some traction bronchiectasis. So, but Betsy, I totally agree with you. This is some sort of fibrotic lung disease that we're dealing with. Is there anything else of value here? And then Betsy mentioned, are those fluffy looking things on the left side, consolidation, infiltrating the left posterior? Yeah, I mean, it's possible. I think the thing that to me looks most like an infiltrator consolidation is actually in the right posterior lobe, like right here. This is all kind of dense, and there's also like some ground glassing here. Now I know this whole picture looks a little bit off from what we're used to looking at, but if you look, this area, yeah, thank you, Betsy. I agree. So this area here is a little bit brighter than the area down here, and certainly brighter than the anterior lung. So I totally agree with you guys. So this person has probably, yeah, a little consolidation, a decent amount of ground glassing, sort of like throughout the lung. It's sort of mosaic here. And then there's also ground glassing here. And also there's a fibrotic pattern, and there's this like tortuous, traction bronchiectasis. Is there anything else here? Maybe a little bit. So I'm not 100% sure what the structure is here that I'm outlining. Again, the picture's not great, but this may or may not be hyaluradenopathy. And I might just be saying that because I know what this disease is because I put these slides together. So this is an example of sarcoidosis. Why did I use this as an example of sarcoidosis and not that picture that I showed you earlier of hyaluradenopathy? The reason that I didn't show you this picture and asked you, what is this, is that what you're looking at here is just hyaluradenopathy. If you're trying to diagnose sarcoidosis, what you really want to see is end organ damage. And we're going to talk about that in a little bit. So this person has clear end organ damage, right? They've got some components that are inflammatory, right? This consolidation and ground glassing that you guys picked up on. And some components that are fibrotic, this interlobular line, this sort of septal line thickening, and this traction bronchiectasis that's associated with it around here. So, you know, does this patient have hyaluradenopathy? I don't know. I'm not a radiologist, but maybe a little bit. because this came up when I typed in sarcoid into Google, right? And I think the bottom line is this is a person that has sarcoidosis, but most importantly, they actually have pulmonary involvement, which is going to sort of trigger you to actually treat them. We're going to talk about that in a second. Okay, last one, and then I will stop torturing you guys. Thomas, do me a favor. Either unmute yourself or you can type in the chat. Doesn't matter to me. Can you tell me where you see the ground glassing?
Kind of all over. I mean,
Yeah, I agree. That's
here,
everywhere.
here. I mean, it's
Yeah,
pretty
the whole
almost. It's very thick though. I mean, the ground glass is almost like a infiltrate, but I mean, just splotchy, kind of splotchy, pattern.
Yeah, I agree. Yeah, it's the whole lung, right? And so when you guys think about ground glassing and infiltrate and consolidation, it's all on the same spectrum. It's just how filled are the alveoli. When they're ground glass, they're a little bit filled with something. When there's an infiltrate, like it's a little bit thicker, they're more filled. And when it's a consolidation, they're just completely chock full of something. So this, I don't know what this is, but this is really, really bad, right? I can't see any air here whatsoever. I'm surprised that this patient honestly is even alive. So this person has acute respiratory distress syndrome. They have diffuse alveolar damage, right? Like, yeah, Betsy, I agree, right? Like the whole thing is white and opaque. So if you looked at this person's chest x-ray, it would be a nightmare. I mean, you wouldn't really even, like you'd probably see mostly white out of their entire lung. This person just has their alveoli completely full of something. And if it's diffuse alveolar damage, that something is blood. And if it's ARDS, that's something maybe like sort of fluid, like non-cardiogenic pulmonary edema type stuff. Now, thickened interlocular septum, yeah, I guess so, but honestly hard to say because the whole thing is so opaque. The other thing that I'm seeing here, which sort of tracks with what we've been talking about, is that there's a lot of air bronchograms, right? So you could see these bronchi like crystal clear. There's no way you'd be able to see them if the entire lung wasn't so opaque. They would be pretty, when the lung was aerated, they wouldn't be well demarcated, unlike these central ones. These central ones you'd still probably be able to see, but these peripheral ones, you see how they're kind of like these faint bronchi? These are air bronchograms specifically because the whole thing is ground glass, consolidated, infiltrated, whatever word you want to use to describe it. What you're seeing is just acute respiratory distress syndrome. This is a picture of acute interstitial pneumonia, and I'm going to talk about that too. And so I'll try to give you guys a good overview of why these things look the way that they do. Oh no, there's a question. I'm going to come back to this, okay? Just remind me, just because I feel like we've been doing a lot of interactivity stuff and not a lot of didactic, and I know that's what you guys came here for. So let me do a little bit of didactic with you guys, and I will come back to this slide in a little bit. Okay, so why don't we start with hypersensitivity pneumonitis? I'm going to start with this one because I hate it, and I want to get it out of the way. It's annoying. So with hypersensitivity pneumonitis, this one is kind of like, it sounds like an occupational type of disease, at least for test taking purposes. So this is a person that's going to go to work at their wheat combine or their parakeet factory or whatever, and they're going to get sick because they're going to get some antigen exposure to whatever, it could be any antigen. And then after they go away from that exposure, they're going to start to feel better. It usually takes like a day or two for them to start to improve. It looks like atypical pneumonia. I mean, this is like hypersensitivity pneumonitis is an inflammatory thing, hence the term pneumonitis, like there's lung inflammation. So mostly the thing that you're going to see is ground glassing. I know I have like the high-res CT findings on the bottom of the slide. You don't have to know that stuff. just know that hypersensitivity pneumonitis, you should see some kind of inflammatory findings. This is really not a fibrotic lung disease. That's not what you're normally going to encounter here. There is a syndrome called bird fancier's disease, right? Chronic hypersensitivity pneumonitis. And that's when somebody doesn't get this treated. Yeah, they can get fibrosis over time. I mean, if you have enough inflammation over enough period of time, you're going to get those changes that we looked at. You're going to get some of that interlobular septal thickening. You're going to get maybe a little honeycombing. You're going to get some traction bronchiectasis. You'll see it. I didn't show you any pictures of HP, but you can get bird fancier's lung. So tell your patients to please stop fancying birds. The way you treat this is you just get them away from the exposure, if you can find it. And sometimes you can. If they've got severe disease, you can give them steroids. This is a steroid responsive condition, but they shouldn't be on steroids for life. So really try to identify their exposure and get them away from it. This condition, you're usually going to diagnose based on the CAT scan. Don't worry, it's not going to be you that diagnoses it. It's going to be the radiologist or the pulmonologist. But just to give you an overview, this is more of an inflammatory thing. And because it's inflammatory, you're probably going to want to use anti-inflammatories like steroids to get it treated, right? So we're going to tailor our treatment on the basis of what kind of condition we're dealing with. Unfortunately, many cases of HP, we never really identify the antigen source, and so the patient does not really do that great with it. So, when you're dealing with this on the boards, it's all hunky-dory. They're like, oh, there's an exposure, they went to work and they got sick. But in real life, a lot of times with HP, we don't actually identify the exposure, and you can't tell them to quit their job and move to another state, right? So this is kind of a tough thing to treat clinically. We're going to come back to this. I forget what this is. All right, so let's talk about IPF. So with idiopathic pulmonary fibrosis, we looked at a picture of this earlier. Let me bring you guys back to what IPF looks like. This is classic IPF, right? So IPF is idiopathic pulmonary fibrosis. It's exactly what it sounds like. It's idiopathic. There is no known cause, and you see only fibrotic changes. So with idiopathic pulmonary fibrosis, it's fibrotic only. There is zero inflammation. And because there's zero inflammation, there's also zero treatment, right? So unfortunately, people who have IPF, there's not a whole lot you can do for them. You can't treat them with steroids. Steroids don't do anything. And as a matter of fact, I actually have this bullet here. When people come in with idiopathic pulmonary fibrosis exacerbations to the hospital, every single doctor will give them steroids, and you shouldn't. I mean, at least you obviously do what you want. I'm not your boss, right? But even though these patients get steroids in the hospital, they get steroids because we don't know what else to do for them. Steroids don't actually work. So if you're asked this question on the boards, don't pick steroids. I mean, if you have a clear IPF patient, don't give them steroids. If they have some ground glassing or some inflammatory stuff on their CAT scan, okay, consider that maybe it's not just IPF, maybe they have something else. But pure IPF, when they get exacerbations, you know what they get exacerbated by? Like rhinovirus. They get exacerbated by the common cold because they have such advanced, they've got such advanced lung disease. So unfortunately, there's not really a whole lot you can do for rhinovirus. You just kind of let them chill, with their scant ground glassing from their rhinovirus, give them some time, and hopefully they get better. There's not really anything to do for them when they get exacerbated. Their prognosis is terrible. So they're usually men over the age of 50. They last 3 to 5 years, and the therapies for them are just awful. We have nintedanib and pirfenidone. They have some benefit, but I mean, it's very marginal, and patients don't really last long even on therapy for this. The real treatment for this is a lung transplant, unfortunately. So, and then as you can see, with high res, it's only fibrotic changes. These patients do not get inflammation. So if you ever see a patient like this with some ground glassing or something, that ground glassing is maybe from something else. It could be like a viral pneumonitis or something. But that's ground glassing, and these inflammatory features are not part of IPF. Bringing additional word salad into this mix, The other name for IPF is idiopathic UIP. UIP stands for usual interstitial pneumonia. So when you hear idiopathic pulmonary fibrosis or usual interstitial pneumonia, you're actually talking about the same thing. These are synonymous entities. Whew, that was a mouthful. Let's get to more of a mouthful. We'll come back to the questions later. So now that we talked about idiopathic pulmonary fibrosis, aka usual interstitial pneumonia, let's talk about non-specific interstitial pneumonia. I hate that these things sound so similar because they're completely different diseases, and it's obnoxious, right? So look at the second line here, right? So contrast non-specific interstitial pneumonia to IPF. IPF is a fibrotic disease. Non-specific interstitial pneumonia is an inflammatory disease. These people actually get ground glassing. There's really nothing else to know about this aside from the fact that it's inflammatory, whereas the other one is fibrotic. So with the fibrotic one, with IPF, you treat them with anti-fibrotics, right? Pirfenidone and nintedanib, and obviously lung transplant. With NSIP, non-specific interstitial pneumonia, because it's inflammatory, look at the therapy, right? It's steroids, it's immunosuppressants. That's kind of what's used for this condition. They don't do great either. I mean, their 5-year mortality is like 25%, but I mean, I think this one is better than IPF. IPF is really a bad thing to have. It's like a cancer diagnosis. NSIP is, I mean, I don't want anybody to get it, but I guess if I had to choose, I'd probably choose NSIP because people, I think, last longer with NSIP. And there's better treatments for it other than using stupid pirfenidone or nintedanib, which don't really do much. But that's it. So those are some of your like big players. All right. So now that we thank you, Thomas. Yes. MCTD is mixed connective tissue disease. So NSIP has like an overlap with rheumatologic conditions. It's found more often in rheumatologic conditions. And, it's so kind of convenient that it's treated with steroids and immunosuppressants because it's like an immune-mediated type of thing. I mean, probably all these things are, but this one, it travels together with rheumatoid arthritis often, or with mixed connective tissue disease often. Okay, deep breath. So when did we start? We started at 5. It's 6:22. Oh man, I have so many things I want to tell you guys. We're going to need another 4 sessions for this. Okay, let's do some questions. I'm very excited. All right, so let's go back to my slides. I just wanted to give you guys a break from the questions because we did so many like interactive things. I want to just like tell you some stuff. So let's see, where's my first question? Let's go with this one for funsies. Okay, so you guys have had a chance to digest this a little bit. So, Sherry asked me, she mentioned when she asked about alpha-1 antitrypsin treatment being used in lung conditions related to Marfan's, EDS, or other collagen-like vascular disorders. So, Sherry, I didn't talk about that earlier. I think that's a great question, and I don't know because I've never seen somebody treated with alpha-1 antitrypsin therapy. So I know obviously it's used in AAT deficiency, but I don't know if it's used in other conditions. So what I'll do is after we finish today, I'll go home and do my homework, and I'll try to come back to you with an answer because that honestly was new to me too. I thought that was just like some random thing that was thrown in with the question. All right, so I'm so happy with the responses here. Okay, I think you guys can tell that this is not a question I stole from elsewhere, and you're just gonna have to suffer through my terrible humor for the rest of the session and next week too. It's just the cost of having to, be in this course with me. So what are we looking at here? So our answers are like a little bit all over the place, right? We're bacterial pneumonia, radiation pneumonitis, AIP, and then like some other crap, right? So I get it. I'm not giving you a whole lot here. I'm just telling you that you've got a guy with some pulmonary symptoms. He's got a history of lung cancer. He has like a very minimal fever, like 100 degrees, and you don't have a radiology read. So like, what are you looking at? So let's look at some of these possibilities, right? So why don't we start, let's go sort of bottom up, right? So bleomycin toxicity, I just want to talk about these because nobody like kind of took a stab at these. So when you have pulmonary toxicity from a medication, you would expect it to be kind of like a diffuse picture. And you're not seeing that here, right? You're seeing that there's really like a unilateral finding on this CAT scan. The left lung is unaffected. So I would be surprised if there was bleomycin toxicity. Now look at what you're dealing with here on the picture. You're not really seeing a frank consolidation, right? So there is a little bit of ground glass in here, right? It's a little bit of a fluffiness to it, but there's no real like dense infiltrate. There's no dense consolidation. If anything, it looks like, there's maybe some of this interlobular septal thickening here, like this bronchus looks like it stands out really nicely. But it's mostly just kind of like a lot of minimal ground glass in here, right? Now, I showed you guys a picture of cryptogenic organized pneumonia earlier, and we'll talk about that in a second. But I think the bottom line is the really nice thing about cryptogenic organized pneumonia is it's got pneumonia in the name, and that's exactly what it looks like. And this doesn't look like pneumonia. Pneumonia should look, or cryptogenic organized pneumonia should look like this bad boy here, right? Where you have these dense infiltrates, and it looks like a typical kind of lobar pneumonia. And you're not seeing that here. You're like, there's no lobar thing. So I think because of that, you can actually get rid of cryptogenic organized pneumonia and bacterial pneumonia, because this is really like an image interpretation question, right? So we're left with radiation pneumonitis and AIP. And by process of elimination, I'm going to show you AIP, which we looked at just now, right? That's not AIP, what we're looking at, right? AIP is like just a disaster. It's like diffuse alveolar damage. So by elimination, this person has radiation pneumonitis. So why did I choose this question? I want to show you guys what radiation pneumonitis look like. If you look at this person, they have like a very linear infiltrate, right? This is where the radiation beam was kind of shot through their chest. The lung that's outside of the radiation beam is completely unaffected, right? So here you have like the sort of the more mediastinal portion of the right lung, and the more like, I don't even know, the more like shoulder portion of the left lung. You're not really seeing that, and the right lung is completely unaffected. So I think you can eliminate the other answers, and really the point of me showing you this question, which I intentionally made ridiculously difficult from the STEM standpoint, is I just wanted you to see radiation pneumonitis. I may have stole this picture from Mixup, I don't know. Okay, so let's look at this question. This was the next one, right? Yeah, let's do this one. Oh my God, you guys are killing me. All right, fine. It clearly wasn't that difficult. So I like showed you a picture of IPF, and now you're just like, it's IPF. All right, fine. So let's talk about why it's not anything else, right? I think that's more the point of this question. So yeah, clearly I'm showing you guys IPF. You're seeing all of the features of IPF. This is exactly what it looks like on every single CAT scan you're ever going to see. So you're getting a lot of this interlobular septal thickening. You see this like letter Y-shaped thing over here and this thing here. You're seeing a lot of this honeycombing back here. I'm not really seeing traction bronchiectasis, but if you showed me like maybe this thing here, like if you showed me a bronchus that didn't look totally normal, I would just call it traction because, you know, all of the fibrosis that this person has. So they clearly have IPF. So why is it not the other things? So we just looked at cryptogenic organized pneumonia, right? It looks like pneumonia, and that's not what this person has. Now, compare and contrast IPF with NSIP. Remember, IPF is a fibrotic lung disease, whereas NSIP is an inflammatory lung disease. So they look totally different, whereas IPF, also known as usual interstitial pneumonia, is that's why it's called usual, right? Like, because like when you see it once, like they all look the same way. So IPF is all fibrotic, non-specific interstitial pneumonia. Mostly is going to have like, you know, ground glassing, a little bit more of that inflammatory flavor. And finally, you kind of get a curveball here. Respiratory bronchiolitis associated interstitial lung disease. Remember, think back, right? RBILD. This is one of the ones that was very, very heavily smoking associated. And if you look at the stem, right, he is having cough over the last 6 months, and he was a smoker, but he stopped smoking 10 years ago. So he's been smoke-free for 10 years. Why would he start to develop RB-ILD progressively now, which is kind of like almost an exclusively smoking-associated ILD? So it's not RB-ILD specific because he's not an active smoker, and it's getting worse despite that, right? Now, obviously, you know, this is IPF, like the picture is easy, but it's not RB-ILD because he's not an active smoker. Now, finally, if you're looking at the spirometry, we kind of like talked about this a little bit earlier, right? So his FEV1 over FVC ratio is actually normal, which is what you would expect, right? He does not have an obstructive lung disease. He has restriction. He's got a lot of lung scarring. And so you can see that his forced vital capacity, 55%, I forget what the cutoff is, it's like 70 or 80. The bottom line is it's like very, very low, right? And remember DLCO, we don't give a shit about DLCO. We're not going to talk about it. All right. Great. Because DLCO is not helpful. So don't bother, like don't bang your head against the wall. Okay. So let's see. So we did IPF. So now we're going here. Right. I love Tom's enthusiasm. He was like, it's definitely B. That's fabulous. Yeah, you guys are right. Yeah, so this is combined pulmonary fibrosis and emphysema, right? So here, so I think the first thing is, who cares about like his symptoms? Doesn't matter, right? He clearly has got to have some sort of lung disease. It's asking to identify what it is. So look at his spirometry to begin with, right? So his forced vital capacity is 110. So and his FEV1 is 95%. So his lung volumes are not actually reduced, right? So he does not, according to his spirometry, he does not have pulmonary restriction. Looking at the FEV1 over FVC ratio, it is reduced, right? So he does have obstructive lung disease. So you know for a fact this guy has COPD, right? Or I guess asthma, but I mean he's a 40-packer smoker. Like he's obviously this is like probably COPD, right? And then the DLCO, who gives a shit, right? Doesn't matter what the DLCO is. Now you get an echo, whatever. He's got some pulmonary hypertension. That's like not surprising. And then you look at his high-risk CT. And what are you guys seeing on the high-risk CT? Why did all of you guys choose combined pulmonary fibrosis and emphysema? What are the findings that made you decide for that? I forget it. I won't belabor the point, right? So fibrosis, right? Yeah, the guy has a lot of these, like a lot of these sort of reticular things, like these interlobular septal lines. He does have some of this peripheral honeycombing, right? That you're seeing in the back here. So he does have like a little bit of this fibrotic pattern peripherally. That's why you guys all chose combined pulmonary fibrosis and emphysema, right? Process of elimination, I think, would make this really easy. It's not acute interstitial pneumonia because we saw that before. That is like the disaster one where they go to the ICU. It's not idiopathic pulmonary fibrosis because that one, we've seen so many pictures of that. It's not, quite nearly that bad. This person has a lot of preserved lung parenchyma, and also strangely, right, his spirometry shows not reduced lung capacities. It's just more obstructive pattern. So that also kind of goes against IPF. And then finally, discriminative interstitial pneumonia. This is one of the other smoking ones. And I'm assuming it looks different. I don't even really know why the answer is wrong. I just know why B is right. So that's that. So that brings me to this. So apparently this is like a disease entity. I didn't realize that it's like its own thing. I always thought that this was just people that had emphysema that also have some fibrosis. I mean, so I don't know. It's kind of like a weird overlap syndrome. And I don't think it's nearly as bad as somebody that has IPF. Like IPF is the worst. So it's not nearly as bad, but obviously you don't want to have either of these things. So that's that. Okay, so we talked about NSIP. So remember, IPF that we talked about earlier, this is the fibrotic one. NSIP is the inflammatory one. And I know they sound very similar, just remember one of them and then remember the other one's the opposite, okay? Great, cryptogenic organized pneumonia. So I know I'm doing a lot of stuff with the words here, right? So cryptogenic means there is no obvious cause. This is probably like an autoimmune thing. And then I have pneumonia bolded because it looks exactly like pneumonia. Like all the features that come in that make you think somebody has pneumonia, that's what cough has, right? They have a fever, they have cough, they've got a pulmonary infiltrate. You look at their CAT scan, it looks like a pulmonary infiltrate. You're going to treat them with antibiotics, right? So the way that you're going to diagnose these people is you're going to treat them with antibiotics first, and then when that doesn't work, you're like, all right, why did they fail? Maybe I should try antibiotics again? I don't know, like, are they like, do you think that they have some weird, like, resistant organism, or do they have like an intrinsic autoimmune lung disease, right? COP has also autoimmune associations, just like NSIP has mixed connective tissue disease associations. And COP is, because it's an inflammatory thing, right, where you're seeing a lot of that like dense like consolidation, I'm losing my mind, the ground glassing. This one is going to be steroid responsive. For the most part, if you look at ILDs kind of as a whole, there's like grade 2C evidence for steroids in pretty much all ILD, with the exception of the heavily fibrotic ones. So you just don't use steroids in IPF. Everything else, I mean, because we don't often have a lot to offer these patients, we just try steroids. But the IPF is the only one where you probably don't want to use it for. Okay. Finally, I know this moment you've all been waiting for, and I hate sarcoid too. So, I'll do my best here. So remember we looked at that sarcoid case earlier, and then I showed you kind of initially the picture of the hyaluronadenopathy, and then I showed you the person who had sarcoidosis that actually had lung disease. So the reason that I wanted to differentiate these for you is that if you've got a patient, so I'm actually going to go to the bottom of the slide and start there. If you've got a patient with only hyaluronadenopathy, you do nothing for them. I mean, you don't have to biopsy them, I guess. It's not do nothing. Just don't biopsy them. It's just adenopathy. Well, so what? Now, obviously, like if they're sick, yeah, I mean, please go after it, because I don't know what that hyaluronadenopathy is. Maybe they have like Hodgkin's lymphoma or another kind of lymphoma or lung cancer, right? Like you don't really know what's an hyaluronadenopathy until you actually get in there. But you don't have to get in there for every patient, right? If you've got like a young, like 23-year-old with no medical problems, and he just has hyaluronadenopathy on like some random chest x-ray that they got for some unrelated reason, you don't really have to chase it. I mean, I would probably get like a PPD or like the interferon gamma release assay, like make sure he doesn't have tuberculosis. But if the dude's not losing weight and his labs are fine, I don't know, you have to biopsy that. You just watch it. So hyaluronadenopathy by itself doesn't really mean anything. With sarcoid, it's when you get end organ involvement that you then have to like go into action, right? So these people will have some pulmonary nodularity. they'll have some of that fibrosis, which I showed you earlier. Let's see, where's that sarcoid lung? Here, right? This is what sarcoid looks like. It's a little bit of a fibrotic disease. They can also have like a little bit of inflammation. Remember that their buzzword is like non-caseating granulomas, and with hypersensitivity pneumonitis, it's poorly formed granulomas. I don't really know how often that stuff appears on tests these days, but I mean, the last time I recertified I initially recertified in, was it like 2013? They love that stuff back then, but now not. I don't know. I don't know how important it is. Sarcoid is steroid responsive. You don't have to know how to dose the steroids. I mean, I know I have it on the slide, but that's not. I mean, I feel like that's outside of the purview of an internist. And I think the biggest issue with sarcoid is obviously it can affect any organ system, right? So I've encountered I've encountered like way too many patients with neurosarcoid, which is like inordinately difficult to diagnose because you have to like brain biopsy them. And we actually Mega, I think, was with me the other day, right? ACE level is not a reliable way to diagnose or exclude sarcoid, unfortunately. The only way to figure out if sarcoid is in an organ is to biopsy that organ. So ideally, you just biopsy their hyaluradenopathy because that's the easiest. But if you don't have a way to get at that, and you think that they might have neurosarcoid, you're kind of have to do a brain biopsy. Like there's not really a lot of good options, unfortunately. Now, getting to some of these sort of sarcoid adjacent syndromes, there are two entities that you guys should kind of like just be aware of. And I'll tell you kind of like how to approach them. So there's Lofgren's and there's Herefort's, right? So with Lofgren's, they get polyarthralgias and erythema nodosa. And with Herefort's, that the other term for it is called uveoparotid fever. I wish they just called it uveoparotid fever because it like perfectly explains what it is. So with uveoparotid fever, they have uveitis, right, eye involvement, parotitis, and fever. Now, also you notice here there's facial nerve palsy. I wonder why, right? They have parotitis. So because they have parotitis, the facial nerve, I think, courses through the parotid gland, and that's why it gets affected. You don't have to biopsy the hyaluradenopathy in these because they're like such classic syndromes. They're like really, really well described. So what you can do when you see a person that has hyaluradenopathy and like some weird shit that like, I don't know, you're like, I think I remember somebody talking about this. It has an eponym, and all you have to do with it is just give them steroids, okay? Like if their symptoms are severe enough to warrant treatment. Not everybody needs to be treated with steroids, especially people with hyaluradenopathy alone. You don't do anything for them. But if they feel bad, if they've got bad Lofgren's or bad Herefort's, I mean, obviously facial nerve palsy is kind of like a morbid thing, right? You're probably going to want to treat them. Just remember, hyaluradenopathy plus some like weird symptom complex, you could probably just give them steroids, and these are like self-limiting conditions. I think they can last sometimes for a while. I think either Lofgren or Herefort's can last for like a year or two, but they go away. So they're not like end organ damaging kinds of things. So you don't have to biopsy them. You can diagnose them just by the clinical picture. And I think the nice thing about the boards, at least from my standpoint, I've never seen a question that gives you like Lofgren's and Herefort's together. So if they give you an eponym, it's probably that eponym. So Thomas asks, is ACE level testing still used to aid diagnosis for sarcoid? Not sensitive since ACE can be high in other diseases. Tom, honestly, I'm not 100% sure. Let me look this up because I haven't read about this literature for a while, but I don't think so. I think the problem with using testing of ACE in any organ is that it's neither sensitive nor specific, right? So not everybody with sarcoid is going to have an elevated ACE, and also people that have an elevated ACE often don't have sarcoid. So it's just not helpful. I think the real struggle here, unfortunately I know this because I've had a few patients with neurosarcoid, it is with neurosarcoid because you diagnose neurosarcoid by doing a brain biopsy, unless you can get tissue from somewhere else, and then you can convince the neurologist that, yeah, they actually, in fact, really do have, bona fide neurosarcoid, because I found these granulomas in their mediastinum. The challenge is sometimes you'll have a patient with neurosarcoid and they don't have hyaluradenopathy, they don't have any other organs involved, it's just their like brain or their CNS. And so we'll typically do an LP on them. And yeah, I mean, our neurologists always get an ACE level, but they do it and ultimately end up having to do a brain biopsy anyway, because it's like, so, okay, so it's like elevated or it's not. It still, unfortunately, doesn't really answer the question for you. And so you're left with this person that has this like enhancing meninges on their MRI, and they have like, you know, new dementia at a young age. And they're just well, like, what am I dealing with? And it's like really hard to treat a person with steroids on the basis of an ACE level, right? Because what's in the meninges? I mean, are you sure it's sarcoid, or is it, I don't know, is it like a lymphomatous spread within their CNS? Or do they have some sort of like exotic CNS infection? Or like some sort of like subacute CNS infection? It's just, there's so many possibilities, and ACE is just not a very good test. But Tom, I'll put that on my list of things to look up for next time, and I'll address it like when we start for next Wednesday. Okay. Oh. Oh. A lot of stuff going on here. I gave you guys so many options. I know I'm a dick. I just, you know, I made this question at like 2 a.m. a couple of days ago, and I was just feeling some type of way. I don't know. So I made the question so we could just kind of like review all like all of the things. Okay, so what? Let me ask for some assistance. So I think this person. I think Thomas is right. I think this person has NSIP. I'm just trying to remember what my thought process was when I made the question. Tom, can I ask you to just walk me through your thought process of like how you got there? Because I was like very sleep deprived, and I need some help.
Well, based on our laboratory studies, she's anemic. Serum reactive protein is normal actually, but she has positive anti-nuclear antibodies and positive anti-SLC semi-antibodies. So it made me think of that she probably had some type of autoimmune disease. And since NSIP is associated with autoimmune conditions, I thought that was the most likely diagnosis.
Tom, I love you. You're like, that's perfect, right? Yeah. So yeah, this is probably NSIP, and that's specifically, I think, the thought process that I had when I was working through this. So if you guys look at the CAT scan, right? Remember, we're really trying to steer between, are we dealing with a fibrotic lung disease, or are we dealing with more inflammatory lung disease? And so here, there's really not a whole lot of fibrosis to see. I mean, you know, I guess I could be convinced, maybe is there like some septal line thickening here? Maybe like a little bit, but mostly what you're seeing here is there's just a lot of ground glassing. You see like some bright segments of the lung here. This is a little bit bright. There's like a fluffy little area of ground glassing here. There's some here. It's kind of like all over, right? So this patient just has like diffuse ground glassing all over the place, right? So she has some sort of inflammatory lung disease. And so on that basis, and then, you know, obviously on the imaging basis of a lot of these other things, then we kind of like move forward with NSIP. So that's why it's NSIP. Let me go through the other stuff and tell you guys why it's sort of less consistent with the other things. Obviously, guys, I know I'm like making this ridiculously difficult. This is, I just wanted to have fun, okay? So number one, RBILD. Remember, this is one of the smoking-associated ones. There's 4 smoking-associated ones. Actually, 2 of them appear on this question, right? RBILD, discriminative interstitial pneumonia, Langerhans cell. Those are three of the sort of classic ones, and then SRIF, right? That's option F. SRIF is smoking-related interstitial fibrosis, right? So RBILD and SRIF are out because this person is not a current smoker. It's not even a past smoker. So those are out. We talked about hypersensitivity pneumonitis. Could this be a picture for hypersensitivity pneumonitis? Yeah, sure, it could be. HP is a more inflammatory type of lung disease that you're seeing inflammation on this. I think the problem with using HP for this question is that this person just doesn't have like any obvious exposure. And when you're dealing with the boards, they're always going to give you like, she goes to work and she gets sick. And then on the weekend, she feels better. So unlikely to be HP, but clinically in the real world, assuming that she didn't have this like autoimmune type stuff, yeah, I think, this could be a CAT scan that looks like HP. Like imaging, obviously, it can be kind of limited to sort of distinguish these conditions from each other. This is not idiopathic pulmonary fibrosis. We have done that one to death, right? So that's all fibrosis. You're not seeing that here. It's not sarcoid because this person doesn't have adenopathy. And also remember, sarcoid, it has like a little bit of nodularity and fibrosis. You kind of get a little bit of everything with sarcoid, and this person doesn't have a little bit of everything. They just have the inflammatory stuff. And then outside of the bullshit answer H, right? This is not cryptogenic organized pneumonia / bronchiolitis obliterans, because that looks like pneumonia. And this person doesn't have pneumonia, right? She doesn't have fever, cough. Well, sorry, she doesn't have fever. She doesn't have that pulmonary infiltrate consolidation. Nothing that looks like pneumonia, right? So I don't know what autoimmune disease she has. I totally had Tom's same perspective, like the anti-topoisomerase one. I was like, no, this is ACP pulmonary, not ACP rheumatology. I refuse to learn it, right? So I don't know what autoimmune disease she has. I'm just not good at that, right? But I know that she has some sort of autoimmune disease, and I know that NSIP has a strong association to it. And she has the picture of NSIP, which is sort of like kind of just diffuse ground glass, right? So yeah, very good. Okay, final stretch. I think we'll be able to get through the ILDs. Oh man, oh my God, we might not even get through them today. Holy crap. All right, sorry. Maybe I need to go faster. Don't worry, I'll make sure we get through everything between today and next week. All right, so acute interstitial pneumonia we talked about, right? So this is the one that just looks like a disaster. There's like ARDS, pulmonary edema. When you biopsy them, it's just like destruction, like they have diffuse alveolar damage. This is a very highly inflammatory thing, and that's why when we looked at that CAT scan earlier, where they had the fluffy infiltrate sort of throughout the whole thing, that's what AIP looks like. They have just ARDS everywhere, and I think the big thing to know about this is very high mortality illness. These people, when they hit the hospital, their mortality rate is like 50 to 75% in the hospital. If you can get them treated, they might do better, but I mean, they're usually they have ARDS on presentation. They get really, really sick. It's a steroid responsive condition. And I mean, I think this is very much up to the critical care doctor that takes care of the patient. But often when you see people go into the ICU and get started on those pulse dose steroids, like the 1,000 milligrams or 500 milligrams of IV methylprednisolone daily, or they get big dose of steroids every day, they're being treated empirically for this entity often. Not always. Obviously, steroids don't necessarily mean a whole lot, but they often are thinking about this specifically when somebody comes in with ARDS of an unknown etiology. You can't tell initially if it's ARDS from just frank pneumonia, or if they have this AIP thing, which is just a really aggressive frank ILD. This is more of pulmonary crit. I'm sure you guys will cover this when we do ACP pulm crit, but I just wanted to show you guys a couple of highlights when it came to ARDS and diffuse alveolar damage. Obviously, these people are going to have pulmonary hypertension, right? Their lungs suck. They're going to be hypoxic. That's going to cause that hypoxic vasoconstriction we talked about last week. Their pulmonary pressures are going to go up. There's nothing specifically to do for the pulmonary hypertension, I guess, although you can try to diurese them if you feel like they're going to tolerate it. They're going to have decreased lung compliance. In other words, you're going to have to put more pressure in them in order to get their lung to expand. So high pressures, and they're not even going to get you good lung volumes because their lungs are just very stiff because they're not compliant, right? They're going to have a huge AA gradient, right? You're going to have to give them lots of oxygen, like 100%, and you're going to have to give them lots of pressure, and they're still going to be hypoxic because their lungs are just devastated. So you can try to diurese them. Obviously, you try to be conservative with fluids if you can, if they're not in shock. Their central venous pressure, I know you guys are internists, you're not doing this, but in general, the target of their central venous pressure should be around 4, right? And that's the goal of that, is to make sure that they have as little fluid in their body as possible. And prone, there's actually like a decent amount of research on prone positioning, like you put the patient like on their chest, like on their face. There is actually some mortality benefit for these patients. So I have like a couple of ICU docs that are friends of mine, and apparently some of them are like really exuberant about proning patients, although it's like, it is a pain in the ass to do. Don't worry, you're not doing it on the floor. Your patients are not will be that sick. A brief shout out to lymphangioliomyomatosis. This is like one of those things. LAM is just you just like review it right before. I'll give you guys a copy of the slides. Just look at this one right before you go for the board so that you recognize this sort of symptom complex. This is like a really not well understood disease. You have smooth muscle that kind of infiltrate the alveoli. The sort of classic 4 things you get, young women get this. They come in with spontaneous pneumothoraces, and when you look at their CAT scan, they have these like cysts in their lungs. You just have to be careful about differentiating that, I guess, from like idiopathic pulmonary fibrosis, because these cysts, they're not going to be as nearly as numerous as that like disaster honeycomb that I showed you earlier. So, just if you've got a young woman, cystic pulmonary changes, spontaneous pneumo, they can also get callus effusions. Think of lymphangioliomyomatosis. You don't have to know the treatment. I think I have sirolimus with a question mark here because I think it's still investigational. Not really great therapy here for it. This is all you have to know about eosinophilic pneumonia. It's really easy. There are eosinophils involved. This is one of the few ILDs that you can actually diagnose by bronchoscopy, because when you do a lavage on them, you get eosinophils. Eosinophils are like an inflammatory thing, and they like steroids. So these people respond very well to steroids. And guess what it looks like? Pneumonia, right? It's in the name. So they get fevers, pulmonary infiltrates, the whole thing. This looks very similar to cryptogenic organized pneumonia. The hallmark here is it's just an eosinophilic syndrome. That's it. They may or may not have peripheral eosinophilia. I think it's sort of dependent on, All right, and I think we'll just finish off with the next one. Pulmonary alveolar proteinuria. So this, you're never going to get a question on this one. It's just too rare. I just love this condition because it's so badass. In this one, pathophysiology is not really well understood here. The alveoli just fill up with protein. I like to mention it because of the treatment, which is a whole lung lavage, which is awesome, right? So obviously you're not going to lavage both of their lungs at the same time because you will kill them. But these people go to the bronchoscopy suite. They get one of their lungs lavaged first to like clean out that protein. Once that lung recovers from like the temporary drowning you gave it, you then lavage the other lung. And I actually have a video of whole lung lavage that I want to show you. I'm having some technical difficulties. Oh, okay, well, I guess the video doesn't work. All right, let's move on. And that's that. All right, why don't I end here? Thank you guys for tolerating my stupid humor for the last 2 hours. And I think, it's almost 7. I'll end off at silicosis. I'll make a note for myself. And we'll pick up at silicosis next week. And let's see, so how much more content do we have to cover? So we're at slide 89. I'm going out to 120. So we might actually finish a little bit early next week. I guess we'll see. The things that we'll do next week is I'll probably review some of this ILD type stuff, although I think we did a pretty good amount of questions on it already. And I feel like you guys got a good concept for my approach to these, like, inflammatory versus fibrotic, steroids versus like the pirfenidone nintedanib type picture. And hopefully I've given you guys just a good framework of like just how to approach these. I don't think that you need to memorize all of these, but that's it. So you guys got it. I'll stay on for a couple minutes if you guys have any questions. And otherwise, I'll see you guys again on Wednesday night.